Thank you, Mark. It's an honor to be here. This is quite an interesting meeting, and Mark Gold is my hero and idol, so I'm really very pleased to be contributing to this meeting. So I changed my presentation based on my observations from yesterday a bit, and thought I would cover three things, which is a lot of things to cover in 10 minutes, and that is the three questions I think are really key and interesting that might be interesting in thinking about treatment centers in the future as well regarding obesity. And that is this concept of, is there a pointer? Here's a pointer. That is this concept of metabolic, normal, and abnormal obesity, the therapeutic efficacy of weight loss reducing body fat, and why does bariatric surgery work? So these are, These are three things that are just quite extraordinary. Why are some people protected from having metabolic abnormalities when they're obese, and other people are prone to having those abnormalities? Why does weight loss cause so many beneficial things? We really don't understand that. And then why does bariatric surgery cause people to eat less food? We really have no clue as to that one as well. And if you think about the metabolic complications of obesity, there's really only a few. There's insulin resistance, along with beta cell failure or dysfunction, which causes diabetes. There's an atherogenic dyslipidemia. It's an increase in triglyceride and small, dense LDL particles and decreased HDL cholesterol concentration. Just LDL cholesterol concentrations is not really associated with obesity. And finally, we know now that having increased fat inside of your liver, increased triglycerides inside of liver cells themselves, is part of this constellation of metabolic abnormalities that are important risk factors for heart disease and stroke. And these really travel together. And actually, we found that having increased fat in your liver, and others as well have found, is a major predictor of who's metabolically abnormal and who's metabolically normal. So two people that look exactly the same BMI, same amount of total body fat, if one of them has increased fat in the liver, they'll have metabolic dysfunction. The one who has no increased fat in the liver, normal liver fat, is metabolically normal. And so it's really extraordinary if you think about the percentage of people that are metabolically normal who are obese. If you look at the NHANES data, and this is very crudely defined as having less than 2 metabolic abnormalities associated with the metabolic syndrome, you see that about a third of men and women are metabolically normal, even though they're obese. And so this is a large portion of the population. If you define metabolic abnormality more rigorously, based on insulin sensitivity. This is a study from just on our subjects, 220 study subjects who did not have diabetes. They had normal oral glucose tolerance. So it's a subset of people with a range of body mass indices, as you can see here. And this is the glucose infusion rate needed to maintain a normal blood sugar during an insulin infusion. So if you're insulin sensitive, you require more glucose infusion to maintain your blood sugar. If you're insulin resistant, you require less because your muscles are not taking up the glucose in response to insulin infusion. And you can see at any given BMI, and I'm talking fast because the clock, where's the clock master? Oh my God. I want the oh my God taken away from my time. But you can see at any BMI, there's a huge range of insulin sensitivity measured by this insulin clamp procedure. So some people are very insulin resistant. Others are insulin sensitive, like a lean person. And these people here tend to have normal liver fat. These tend to have high liver fat. And so one question is, are these really the same people, but you just have to wait a little longer, and then over time, these people will become these people? So we actually looked at this by taking a group of metabolically normal people who are obese here and a group of metabolically abnormal obese people here, and we overfed them using the best metabolic kitchens that we have in the country. Using fast food restaurants is less expensive, more palatable than any metabolic kitchen of any clinical research unit. The food is completely reproducible. A cheeseburger, Tuesday is the same as a cheeseburger, next Thursday. And it's inexpensive, and so we had our dietitian counsel our subjects to eat 1,000 extra calories a day who are metabolically normal here or metabolic abnormal. You can see she did quite well. They really, in terms of very carefully done diet records, they ate 1,000 extra calories a day with the same macronutrient composition, so same amount of percent fat, carbohydrate, protein, until they gained 6% of their body weight. And so we studied them before and after a 6% weight gain. And what we found is actually quite extraordinary. And this is not yet published, so we can't put this on the web. But both groups, normal and abnormal, gained 6% of their body weight. Change in fat mass was the same, but the change in intrahepatic triglyceride content was very different. those who were metabolically normal were protected from increasing their liver fat content, and they were protected from increasing their visceral adipose tissue content. So despite gaining the same amount of weight, the distribution of triglyceride was very different between the two groups. And then if you look at insulin sensitivity with this clamp procedure, infusing insulin at a certain dose and looking at whether it suppresses lipolysis, the breakdown of triglyceride and adipose tissue, which is a measure of insulin sensitivity in fat, and also stimulating glucose uptake by muscle, a measure of insulin sensitivity in muscle tissue, you see that the metabolically abnormal people got much worse, less glucose uptake and less suppression of lipolysis, whereas the metabolically normal group didn't really change. They were protected from this 6% weight gain. So this is really quite amazing if this holds up. What is it about some people who are resistant to the increase in body weight and others who are prone? And this gives you implications of who should be treated in obesity treatment centers if you're worried about metabolic complications. These people who are metabolically normal do not really go on to develop diabetes and heart disease at nearly the same rate or frequency as these people who are metabolically abnormal. Now, the next thing is that to understand that every bit of weight loss has amazing therapeutic benefits. It's a progressive improvement. The more weight you lose, the better is your metabolic profile. And so here's data from the Look Ahead study showing that the effect in glucose concentrations, triglyceride concentrations, HDL concentrations here, blood pressure, systolic and diastolic blood pressure, every % increase in weight loss is a greater reduction or improvement in HDL, greater reduction in blood pressure, greater improvement in all the metabolic complications. So even a 2% weight loss causes metabolic benefits, 10% even more. And we don't know when it stops, but really at least up to 15%, you still get this progressive improvement by increasing weight loss. So one principle is certainly a little bit of weight loss is very good, and more is even better. So we hypothesized that if a little bit of losing fat is so healthy, but it's so difficult to get people to lose 5%, of their body weight, maybe we could do this more easily by just sucking out the fat. And so liposuction is the most common cosmetic surgical procedure in the U.S. There are more than 400,000 liposuction procedures performed every year. And so we had our surgeon, plastic surgeon, remove 10 kilograms of subcutaneous body fat from obese women that had normal oral glucose tolerance and diabetic. And you can see here this thick paniculus of fat has really been removed. This is 10 kilograms of abdominal fat that's removed, equal to a 12% weight loss had they lost that fat by dieting. And what's amazing is that this has no beneficial effect on any of the metabolic risk factors for heart disease or diabetes. So blood pressure, glucose, insulin, triglycerides after are the same before. I'm not going to show you other data, but insulin sensitivity is identical in the clamp procedure. So losing fat by removing it surgically does not cause therapeutic benefits on metabolic profile. Certainly makes you more svelte and beautiful, as you can see here, and it changes your fashion sense to a thong instead of this here. But now I know HR is going to. Yes.
That's allowed
But,
here.
okay, so yeah, with you, I know everything goes with Mark Gold in the room. With Mark Gold, I look really conservative and Amish-like, really. So what this study tells you, to get the beneficial of weight loss, you have to eat less and exercise more, which is something that's quite unique. Because when you do that, you shrink the size of your fat cells, you eliminate fat in the liver and in visceral adipose tissue. But if you suck out fat, you just remove billions of fat cells, but don't do anything to the remaining milieu. Now, the final thing I want to just touch on very quickly is bariatric surgery, because this is just quite amazing. Bariatric surgery is the most effective therapy for getting people to eat less food and lose weight. This is data from the Swedish obese subjects trial going out 20 years. And look at this gastric bypass, 25, 30% weight loss, out to 20 years. Banding, you get about a 15, 20% weight loss out to 20 years. It's quite remarkable that these surgeries cause people to lose weight. And what's the mechanism? What is the control that these procedures make people reduce their drive to eat food? What's happening to the reward mechanism that makes people eat more food even when you're full? If you had a steak for dinner or had the chicken for dinner last night and they brought you another piece of chicken for dessert, you would have passed on that chicken. But because they brought you ice cream and the sweet thing, you ate it because you wanted it and liked it. And so we just finished this little study. This is Yanina Pepina from Argentina did this study. She's a taste expert in our group, where we took people who had bariatric surgery and found that about 30% were positive addicts for food based on the Yale Food Addiction Scale before surgery. And after surgery, none of them. Only one person still was positive. So bariatric surgery, this is banding, gastric bypass, sleeve gastrectomy, all of them eliminate food addiction in people who are obese. And you can see food cravings go way down as well in the food-addicted group, and even goes down in the non-food-addicted group, but even more in the food-addicted group. So I want to just end with this, is that for RiverMend, this is the challenge that and you don't have to be kosher to appreciate this, but you walk through life and you get all of these, temptations to eat food, to stop, to rest, to don't walk, until you get to the promised land, over here. But if you can get people here without stopping too much, they'll really get a reward, because in here, you can see, there are people waiting. Okay. Yeah. I'm done. Yeah. That's it. All right, thank you.